There is a particular kind of courage that does not announce itself. It does not ride into town on horseback or fire a gun or plant a flag on new ground. It does not leave the kind of record that newspapers print or monuments commemorate. It happens in small rooms and canvas-covered wagons and sod houses on the open plains, attended by 2 or 3 women, or sometimes by no one at all, and it is over one way or another before most of the world knows it has begun. Between 1840 and 1880, somewhere between 250,000 million people crossed the American continent by wagon train. Among them were thousands of pregnant women. Some knew they were pregnant when they left. Some did not yet know. Some became pregnant on the trail and carried their pregnancies through the most demanding physical conditions that civilian life in 19th century America could produce: the dust, the heat, the cold, the jolting of wagon wheels over ground that had never been smooth for travel.
Open your mouth.
The inadequate food, the contaminated water.
I can't.
The exhaustion of 6 months of relentless movement through terrain that challenged the strongest men in the party. And at the end of that journey, or sometimes in the middle of it, they gave birth. Without hospitals, without the physicians whose limitations we have already examined, and who were, in many cases, absent rather than present, which was, as we shall see, sometimes a mercy. Without the family networks that had surrounded childbirth in the communities they had left behind, without the specific knowledge that accumulated across generations of women living in the same place, knowing each other's histories, available to each other in the moments that mattered most, with whatever they had, with whoever was there, with the knowledge they had brought with them, and the knowledge they improvised in the moment, the particular kind of determination that characterized the women who made this journey and is consistently underrepresented in the history of it. Most of them survived. The rate at which they did, given the conditions, is worth examining carefully because it reveals something important about what actually keeps people alive in difficult circumstances. And it is not always what the official record suggests. To understand what frontier childbirth required, it is necessary to first understand what childbirth looked like in the mid-19th century. Even under the best available circumstances, childbirth in 1850 was the leading cause of death among women of childbearing age in the United States. Not because it was inherently more dangerous than it is today. The biological process was the same, but because the knowledge and practices surrounding it were in many specific respects inadequate or actively harmful in ways that we have already touched on in the context of frontier medicine generally. The germ theory of disease was not yet established. The understanding that infections could be transmitted on unwashed hands, on unclean instruments, on contaminated cloth, was not yet part of medical practice. Physicians who attended births in the mid-19th century did not wash their hands between patients in the way that modern medicine demands, because they did not yet understand that there was a reason to. Ignaz Semmelweis, the Hungarian physician who demonstrated in the 1840s that hand-washing dramatically reduced maternal mortality in hospital settings, was dismissed, ridiculed, and institutionalized by the medical establishment of his era. His ideas did not become standard practice until after his death. This is not a digression. It is the central fact of the childbirth story, because in the absence of the germ theory, in the absence of the practices that germ theory requires, the most dangerous place to give birth in the mid-19th century was not a canvas wagon on the open plains. It was a hospital, or a physician's examination room, or any setting where multiple patients were attended by the same hands without adequate cleaning between them. The women who gave birth on the frontier, attended by other women or attended by no one, were in some respects safer than the women who gave birth in urban settings with access to formal medical care. Not because the frontier was medically sophisticated, because it was medically isolated, and isolation in this specific historical context prevented the transmission of the infections that were killing women in the hospitals. This is one of the more counterintuitive facts in the history of frontier medicine, and it deserves to be held clearly. The women who attended births on the frontier, the midwives, the experienced mothers, the neighbors who were summoned across miles of open country when labor began, carried knowledge that had been accumulated over generations of women attending women in exactly these circumstances. This knowledge was not written in books. The formal medical literature of the period, which was written by men for men, treated childbirth as a medical event requiring medical intervention, the application of instruments, the administration of compounds, the management of the birth process as if it were a mechanical problem to be solved rather than a physiological process to be supported. The women who actually attended the majority of births in frontier America operated from a different knowledge base, one that had been developed and refined through direct experience, and that encoded in its practices a practical wisdom about what helped and what harmed that the formal medical establishment had not yet arrived at theoretically. The core of this knowledge was something that sounds almost too simple to be important: patience. The understanding that birth in the great majority of cases is a process that the body knows how to accomplish, and that the most important thing a birth attendant can do is create the conditions in which that process can proceed without disruption. Warmth, calm, adequate hydration for the laboring woman, the specific physical support that reduces exhaustion and anxiety, and the experience to distinguish the complications that require intervention from the difficulties that are simply part of a process that is proceeding correctly. This sounds simple. It was not simple to practice. It required the capacity to remain calm in circumstances that were frightening. It required the experience to recognize the difference between normal labor, which is painful and exhausting and frightening even when it is proceeding correctly, and abnormal labor, where the difference between intervention and waiting could mean the difference between life and death. It required the specific knowledge of what interventions were available and when to apply them, which herbs had genuine physiological effects and which were primarily comforting, which positions helped and which did not, what the specific signs of the most dangerous complications looked like, and what could be done about them in conditions without any of the resources that formal medicine relied on. The herbs and plant-based preparations that frontier midwives used in labor and delivery represent one of the more complex dimensions of this history. Complex because they were neither the crude superstition that dismissive accounts have sometimes made them out to be, nor the reliable medicine that their advocates claimed. Some of them worked. Blue cohosh and black cohosh, plants native to North America and widely used by both Native American midwives and Euro-American women, contain compounds that have genuine effects on uterine contractions. Their use in labor, primarily to stimulate or strengthen contractions in labors that were proceeding slowly, had a physiological basis that was real, even if the women who used them understood it in terms of traditional knowledge rather than organic chemistry. Raspberry leaf tea, widely used in the final weeks of pregnancy and during labor, contains compounds that may have genuine tonic effects on uterine muscle. The evidence for this is not as strong as the traditional conviction in its effectiveness, but neither is it absent. Women who consumed it throughout their pregnancies were, at minimum, maintaining hydration and consuming something that was not harmful, which, in a medical landscape where many available interventions were actively harmful, was itself a form of practical wisdom. Ergot, a fungus that grows on rye and other grains, was used by some midwives to stimulate contractions in labors that had stalled. It contains ergotamine, a compound with powerful effects on smooth muscle, including uterine muscle. Ergotamine-derived compounds are still used in modern obstetric medicine in carefully controlled doses for specific indications. The frontier use of ergot was less controlled and more dangerous. The margin between an effective dose and a toxic one was narrow, and the natural variation in ergot concentration made dosing unreliable. But the underlying principle, that a physiologically active compound could be used to manage a specific obstetric problem, was sound. This is the pattern that recurs throughout the history of frontier women's medical knowledge. Practices that were not scientifically understood but that were, in a significant number of cases, empirically grounded in real effects that had been observed and tested across generations of use. Not reliable in the way that modern controlled clinical trials make medicine reliable, but not arbitrary either, tested against consequences in the way that only genuine life or death stakes can test knowledge, and surviving that testing because they worked often enough to be worth transmitting. The journals and letters of frontier women contain accounts of childbirth that, read carefully, reveal the specific texture of what this experience was like, not as abstracted statistics, but as the lived reality of individual women in individual circumstances. A woman named Amelia Knight, who traveled the Oregon Trail in 1853, kept a diary of the journey that includes a matter-of-fact account of giving birth while the wagon train was still on the move. She had been in labor through a day of travel, had delivered with the assistance of another woman in the party, and was back on the trail within days. Her account of the birth itself is brief, a few sentences, and her account of her return to the demands of trail life is equally brief. The brevity is not indifference. It is the specific matter-of-factness of someone for whom this experience, as extraordinary as it was also simply something that had happened and was now behind her and could not be dwelled upon because the trail required her attention. This quality, the absorption of extraordinary difficulty into the ordinary fabric of continuing life, appears consistently in the accounts of frontier women who gave birth on the trail or in early settlement conditions. It is easy to mistake for toughness, in the simple sense of an emotional hardness or insensibility to suffering. It was not that. These women felt what they felt. They were frightened and exhausted and in pain. What they had developed through the necessity of their circumstances was a particular kind of forward orientation. The understanding that the suffering was real, and that it was also in some essential sense beside the point, because the trail was still ahead, and the children needed attending and the practical demands of survival did not pause for grief or fear. This is not a model that should be romanticized or held up as an ideal. It came at a cost that the records also reveal, in the depression and the grief and the exhaustion that appear in the private writings of women who had learned to keep moving regardless of what was happening inside them. But it is a real quality, and it deserves to be understood on its own terms rather than filtered through either sentimentality or dismissal. The complications of childbirth on the frontier, the cases where the process did not proceed normally, and where the resources of the attending women were genuinely tested, are recorded with particular honesty in the journals of women who survived them, and, in some cases, in the accounts of survivors who recorded what had happened to women who did not. Hemorrhage was the most immediately life-threatening complication, and the one for which frontier midwives had the most limited resources. Postpartum hemorrhage, bleeding that continues or increases after delivery, can cause death within an hour in severe cases. The interventions available on the frontier were primarily manual, external massage of the uterus to encourage it to contract and compress the blood vessels, the use of ergot or other uterotonic plants if available, positioning to reduce blood pressure at the bleeding site. These interventions were sometimes effective and sometimes not, and the difference between a woman who survived a severe postpartum hemorrhage and one who did not was often a function of how quickly the hemorrhage was recognized, how experienced the attendant was, and factors, the specific anatomy of the bleeding, the underlying health of the patient, that no level of frontier expertise could control. Obstructed labor, a labor in which the baby cannot be delivered normally due to its position or size, was the complication that frontier midwives most feared and were least equipped to manage. In a modern hospital, obstructed labor is managed with cesarean section, an operation that has been possible since the late 19th century, but that was, in the frontier context, essentially unavailable. A skilled frontier midwife could attempt to manually reposition a baby that was poorly presented, turning a breech baby, correcting a transverse lie, and these maneuvers, performed with skill and at the right moment in labor, could convert a life-threatening situation into a manageable one. But they required skill that not every attendant had, and they had to be performed at a specific window of time in labor, when the cervix was sufficiently dilated and the baby was not yet so deeply engaged that repositioning was impossible. The accounts of these situations in frontier journals are among the most difficult documents to read in the entire history of the overland crossing, not because they are melodramatic. They are characteristically understated, described in the same matter-of-fact voice that recorded the death of an ox or the breakdown of a wagon wheel, but because the understatement makes the reality more present, not less. A woman noting in her diary that her neighbor had labored for 3 days and that the baby had not come, and that they had done what they could, and then a gap of 2 days, and then a brief entry about a grave. This is a document that requires no elaboration. The question of who attended frontier births and what determined the quality of the care available varied enormously by location, timing, and circumstance, and the variation is instructive. On the organized wagon trains, births were attended by whatever women were in the party, with the most experienced woman in labor and delivery taking the lead. The experience of that woman varied from party to party. A woman who had herself given birth several times, and who had attended the births of sisters or neighbors before leaving her home community, brought a body of practical knowledge to the role that was genuinely valuable. A young woman who had never attended a birth and was managing her first pregnancy simultaneously was in a genuinely difficult situation. The Native American women whose paths crossed those of the wagon trains were sometimes, not always, not often, but sometimes, a resource. There are accounts in frontier journals of Native women providing assistance, knowledge, or material help to women in labor on the trail. These accounts tend to be brief and sometimes condescending in their framing, but they record a real phenomenon: the transmission of practical knowledge across cultural difference, driven by the universal urgency of a woman in labor and the specific expertise of women who had been managing birth in these specific environmental conditions for far longer than the immigrants had been there. The Mormon communities that established permanent settlements in Utah from the late 1840s onward developed a more systematic approach to frontier midwifery than most other emigrant groups, driven partly by their communal organization and partly by the specific theological significance that the community attached to birth and family. The Relief Society, a women's organization within the Mormon Church, trained midwives systematically, maintained records of births and complications, and created a network of experienced attendants that could be called upon across the settlements. The maternal mortality rate in early Utah settlements was, by the standards of the period, relatively low, a fact that the historical record attributes, at least in part, to this systematic approach to birth attendants. This is worth noting because it illustrates a principle that appears repeatedly across the history of frontier survival. Systematic organization and the deliberate transmission of practical knowledge produces better outcomes than individual ingenuity alone, even when the knowledge being transmitted is incomplete by modern standards. The Mormon midwifery network did not have access to germ theory or modern obstetric techniques, but had experienced practitioners, a system for developing and transmitting their experience, and a community structure that ensured their availability. This was enough to produce a meaningful difference in outcomes. The sod houses and homestead cabins where so many frontier births took place deserved their own examination, because the physical environment of birth was itself a factor in its outcomes, and not always in the ways that modern assumptions might predict. The sod house was, by any aesthetic standard, a grim place to give birth, built from blocks of prairie turf with earthen floors, minimal light, and a tendency to leak in rain and harbor insects in summer. It offered none of the comforts associated with domesticity. It was, however, warm in winter, a quality that was not trivial in the context of births that occurred on the northern plains in November or December. It was private in a way that the canvas wagon was not, and it was stationary, a quality whose value is not apparent until you consider the alternative. Births that occurred while the wagon train was in motion were attended by a particular set of additional difficulties. The wagon could be stopped, and typically was when labor advanced sufficiently, but the surrounding party was not always willing or able to remain stopped for the duration of a labor that might last many hours or days. The pressure to keep moving, driven by the calendar and the awareness that every day's delay increased the risk of arriving at the mountain passes too late in the season, was real and sometimes intense. The accounts of women who labored and delivered while the wagon train continued moving, who gave birth in a wagon that was still being jolted across uneven ground, are not common, but they exist, and they represent the specific cruelty of a situation in which the collective urgency of the group could not fully accommodate the individual urgency of a single laboring woman. In the homestead cabin, this pressure was absent. The birth could take the time it needed. The woman could move, could change positions, could walk if walking helped, could rest when rest was possible. The cabin was a fixed point in a world of movement, and for the purposes of birth, fixity was a genuine advantage. There were women on the frontier who became over the years of settlement genuinely skilled practitioners of the art of attending birth. Women whose reputations spread across distances that we would now consider impractical, who were sent for by wagon or on horseback, and who traveled many miles through difficult conditions to attend women they sometimes had never met. These women occupy a particular place in the history of frontier medicine. They were not trained in any formal sense. They had no credentials, no certificates, no institutional affiliation. What they had was experience, accumulated across dozens or hundreds of births, refined through the specific testing that only real consequences can provide, and transmitted through the networks of women who knew each other across the distances of frontier settlement. A woman named Patty Sessions, who traveled to Utah with the Mormon pioneers in 1847, kept detailed records of her midwifery practice that have survived as one of the most comprehensive documents of frontier birth attendants in the historical record. She attended over 3,000 births across the decades of her practice in Utah. Her records include the outcomes of those births, the complications she encountered, the interventions she used, and in a habit of mind that was uncommon among practitioners of any kind in her era, her assessment of what had worked and what had not. Patty Sessions did not have the vocabulary of modern medicine. She did not know about germs or about the specific pharmacology of the plants she used, but she had something that the formally trained physicians of her era frequently lacked: a genuine commitment to learning from her outcomes rather than explaining them away. When an intervention did not produce the expected result, she noted it. When a complication recurred, she attempted to identify the pattern. When something worked in a case where she had not expected it to work, she asked why. This habit, the willingness to let outcomes inform practice rather than forcing outcomes to conform to existing theory, is the same quality that distinguished the good frontier doctors from the bad ones, the successful wagon train captains from the failed ones, the desert water redders from the travelers who arrived at dry springs. It is not a specialized quality, it is a general one, and its rarity in the historical record of the frontier is itself one of the more instructive facts that the record contains. The children who were born on the overland trail and in the early frontier settlements occupy a specific place in American demographic history that is worth noting. They were, by the evidence of the records, born in roughly the expected proportions of healthy to compromised, slightly more infant deaths than in established communities as would be expected given the conditions, but not the catastrophic excess that the circumstances might suggest. This is partly a function of the selection effect that operated on the emigrant population as a whole. The people who undertook the overland crossing were, on average, younger and healthier than the general population they had left behind. The women who survived the physical demands of the trail to reach the point of giving birth on it had already demonstrated a degree of physical resilience that was not universal. The births that resulted were, on average, attended by mothers who were physically capable and psychologically prepared, in the specific way that people who have survived significant hardship are prepared for whatever came next. But selection effect does not explain everything. Some of what the records show is the result of the specific practices of frontier birth attendants. The patience, the avoidance of the harmful interventions of formal medicine, the genuine skill of experienced practitioners, the community organization that, in the best cases, ensured that no woman faced the critical moments entirely alone. The frontier was not a good place to give birth. It was better than some of the alternatives that a different understanding of its dangers might suggest. And the reason it was better was not primarily the absence of medical intervention, though that paradoxically sometimes helped, but the presence of knowledge, experience, and the specific human quality of women who understood what was needed and provided it, in circumstances that did not make providing it easy. There is a broader truth in the history of frontier childbirth that connects to every other story this channel has told and will tell. The women who attended births on the frontier did not have the luxury of theory. They had outcomes. Every birth they attended told them something about what worked and what did not. Not in the abstract, not in a controlled experiment, but in the specific, irreversible, life or death context that the frontier imposed on everything it touched. They could not afford the comfortable error of the physician who attributed patient deaths to the disease rather than the treatment. The births they attended were in the same community, witnessed by the same women, evaluated by the same people who would call on them again. Their outcomes were visible. Their errors had social consequences. This accountability, partial, imperfect, entirely informal, was more than some practitioners of the era had, and it produced, across the years and the miles and the thousands of births that were attended in these conditions, a body of practical knowledge that was genuinely useful, not complete, not modern, but grounded in reality, in the way that only consequences can ground knowledge, and transmitted with the care that only people who understood its value could transmit it. The canvas of the wagon is long since rotted. The sod houses have returned to the prairie. The wooden grave markers of the women who did not survive have been taken by time, their names half remembered or forgotten. But the knowledge that the women who survived them carried, and the specific quality of attention and care and practical intelligence that that knowledge represented, this was real. It happened. It kept people alive who would otherwise have died. It deserves its place in the record of what the frontier required, and what the people who crossed it found within themselves to provide. The morning comes early on the plains, and the light is the same light it has always been. The grass bends. Somewhere in the distance, a wagon is moving. And in it, or beside it, or in a sod house visible from the trail, a woman is doing the oldest and most consequential work that has ever been done, bringing a life into a world that does not pause to acknowledge the difficulty of the arrival. She knows what she is doing, or she is learning, in the only way the frontier permitted, by doing it with what she has under the sky that does not hurry, and the land that does not soften, in the specific, unromantic, absolutely real courage of someone who has no choice but to be equal to what the moment requires.